in the addiction fields for years. And then the Massachusetts Association for Mental Health has been working for decades to address disparities in health service access. I'll hand it back to Deb here.
Thanks. Our other sponsors include the Criminal Justice Policy Coalition, which I'm a proud board member of. They've been doing work advancing policy related to having a more just criminal legal system here in Massachusetts. And specifically, they've done work on ending life without parole. So their board president, Cynthia, and director, Linda, have been such big supporters of this work. And next, I want to thank Boston Medical Center's Graken Center for Addiction, where I'm grateful to work and spend time addressing both behavioral health access issues and the criminalization of addiction. And a special shout out to the office-based addiction treatment training and technical assistance program, who's running all of the logistics tonight and puts on an amazing series of trainings throughout the year. A few more housekeeping items. We're going to have the chat function turned on tonight. We want to leverage all the knowledge and experience of our attendees. Feel free to use the chat function to engage in the material, of course, being respectful of the panelists and other attendees. We're going to hopefully have about 10 to 15 minutes at the end for questions. We'll pull those questions directly from the chat. We're also going to have a few folks covering various areas, covering the chat. There are folks that cover various areas of expertise, and they're going to help answer questions in real time. This includes Deanna, Alicia, and Brendan from Boston Medical Center and Rachel from Prisoner Legal Services. We are recording this event for folks who are interested but unable to attend. However, we're not going to record content in the chat, and we're going to turn off recording during the Q&A section at the end. I'm going to hand it off to Kira now, who's going to explain information on continuing ed credits. We know not everyone tonight is seeking these credits, but we really welcome all the healthcare professionals here who want to learn more about advocacy.
Hi, my name is Kira. I'm the program coordinator for the OBAT TTA team, so I'll be here taking attendance, and you can feel free to chat me with any technical issues. We really appreciate if you do have your camera on if you're requesting credits. If you have any issues at all, again, feel free to reach out to me and my colleague Victoria, who will be here as well.
Hi, I'm Victoria. I'll be here for admin support. Let me know. Feel free to message in if you need anything. Thank you.
Great. So, Deb, we ready to get started?
Sure, yeah.
Great. Okay. So just as a bit of background, we know people are coming to this with various levels of understanding and experience with what we're talking about tonight. So we just kind of wanted to set the stage a little bit. So tonight we're going to concentrate on a specific piece of legislation, which we're going to hear more about from the experts, which moves to reform our current Section 35 system. So Section 35 is referring to a process that we have here in Massachusetts that civilly commits individuals for substance use disorders. It means that they are placed in treatment involuntarily. This comes on a background of having a long history of criminalizing addiction in many ways in our country and in our state. And we feel like our Section 35 process here is really kind of a perfect example of how we have perpetuated stigma and caused harm to individuals and communities through our policies towards addiction. We want to recognize that this bill is a step for reform, and it is that there is a place for larger reforms and even abolition of the system altogether. And we know that there's a diversity in views when it comes to this. I know this as a medical provider, and we all come to this with our different experiences and opinions on this. And that even on this panel, we may not agree on a final solution, but we do, at least on this panel, all agree that we should not be using correctional settings for substance use treatment. Our current system is punitive, ineffective, and avoidable, and reform is long overdue. I am so grateful to be part of this community and grateful to the advocacy groups, our legislators, the medical community, and those that have been personally impacted and have had the amazing courage and bravery to come and speak with us tonight and take action. So I'm excited to hand it off now to the people that we're here to hear from, the experts. So, not quite yet though. First, I have to introduce our first expert. So I have the great pleasure of introducing Bonnie Tenneriello, who has been a staff attorney with PLS since 2004. During this time, she has litigated numerous systemic prison reform cases, some of which you'll hear about tonight. She has educated me tremendously on this issue, and I'm sure you will enjoy learning from her as well. She's the PLS representative to the legislatively created Restrictive Housing Oversight Committee. Before PLS, she was an attorney with the National Voting Rights Institute, served as a Skaden Fellow with the Farm Workers Legal Services of Michigan, and clerked for the Honorable John Fakins. She's a graduate of the University of Michigan Law School. So with that, I hand it over to Bonnie.
Thank you. I have more of an introduction than I deserve, but thank you. And I really appreciate Alice, Deb, and the other organizers for pulling this together. It's been terrific for the legal community and the medical community to be working more closely together, and really appreciate your work to help that happen. And I really want to thank Representative Balser. She's been on this issue for a long time and really passionate about it, and really appreciate her leadership on that. Your leadership, Representative Balser. There are a number of states that do it, as Alice was saying, committing people for treatment, saying you're a danger to yourself or others, so we're gonna have to force you to get treatment, is not unique to Massachusetts, but we are the only state that uses prison to do this. And remember, we're committing people for treatment, not because they've done anything wrong, but because they need treatment. And our officials in Massachusetts have acknowledged that this is wrong to use prison for decades. There was a panel back in 1989, a governor's panel that said this, and other panels and government consultants since then. And recently in 2015, Governor Baker's opioid working group recommended that you should take Section 35 away from DOC and put it in all of it in the office of the Executive Office of Health and Human Services. And they said, we need a clinical environment, not a correctional setting. And as recently as 2019, there was a very diverse commission set up by the legislature, which Representative Balser served on, but it contained a wide variety of people from law enforcement, addiction medicine, all over the courts, and that also recommended prohibiting the use of any criminal justice facility, and recommended expanding other treatments. So we know this, and the Baker administration has a State Without Stigma website, which says stigma creates barriers and can prevent people from getting treatment or staying in recovery. So, of course, prison is the ultimate stigmatizing experience. So we have to ask ourselves, if the administration knows this, why are we still putting treatment resources into correctional facilities rather than healthcare settings? And just Friday, we learned that the state is planning to double down on this. They want to invest at least $36 million more in the DOC's Section 35 facility. So, rather than saying this, and we're talking about the administration as a whole, rather than saying, let's shift this over to Health and Human Services, let's roll out more resources there, they're doubling down on a harmful strategy. Just to give you a minute of background, PLS was part of a legal team that sued to end civil commitment in prison for women. And as that litigation was pending, and as the legislation was pending, in 2016, the statute was changed so that women can't be sent to prison only by virtue of a civil commitment. If they have criminal charges as well, they still can be under certain, so women now, there's enough space for all women to be held in DPH contracted facilities or in a DMA, Department of Mental Health facility. And even women who, the statute says some people, if the court finds you need a secure facility, then you have to be sent to one. And even women who are sectioned with this court finding that they need a secure facility, they go to the Department of Mental Health. So the Department of Mental Health and the Department of Public Health now oversee enough beds for all civilly committed women, including those who are found to need a secure facility. But for men, over 70% who are committed still go to the Department of Correction, or the statute allows the Department of Correction to contract, to reach agreements with others. So the Department of Correction and Hampden County have a memorandum of understanding that allows the Hampden County Sheriff's Department to also hold people. So 70% of men who get sectioned go there, not because they, and nearly always, it's not because a court found they needed more security, just because there's not enough beds for them in treatment settings. And these are traumatizing and shame-inducing environments. You know, for years we have been talking to men held in these facilities. They come in through the prison gates. They're shackled. They're strip searched. They're held in the facilities call it isolation. We call it solitary confinement under certain conditions. The staff supervising them is trained in the correctional environment, even though now in both facilities, they're no longer called corrections officers. Many of them do have a history or even have worked as corrections officers from what we've been told. We're still waiting to get data on that, but this is what our clients have told us. Things like, just 15 minutes to eat, having a million rules. There's a million ways in which it feels like a prison rather than a healthcare center.
I put it off just for a second because I needed to get up for a minute. I'll put it right back on.
And mute everyone who's not.
Make sure you're muted, everyone.
I think the whoever can whoever's got the controls mute everyone. So I just gotta, so like I said, they pulled, they're now claiming that, that the people overseeing the patients are not corrections officers, but the environment still correctional. I just heard voicemail today from a guy at Masac who said he was a prisoner, who considered himself a prisoner, having yet spoken with him. And in the course of our litigation, as we've had people say, well, I feel like I'm an inmate, even though I've never done a crime. One guy in Hampden County said, putting us in jail sends the message you're bad. It also upsets our families who don't want us to be in jail. Other people are ashamed to contact their employers or other contacts in the community from a correctional facility. They're ashamed. It creates rifts with their family. There's a million ways in which it's counterproductive and traumatizing. And, but the more fundamental point is that no matter how nice you make the environment, a prison is not where we should be sending people for treatment. When you send people through the prison gates, you're telling them they've done something wrong. And you're instilling a sense of shame in that patient, and a sense you're telling the community this is where people with addiction belong. And that, as the Baker administration has acknowledged, that's a barrier to recovery, and it discourages people from seeking treatment. And this is really heartbreaking. We've seen parents in an agonizing situation where they feel they had no other option but to section their child, knowing he might end up in prison. And then the anger of the child who ends up in prison, and the anger of the parents' horror at seeing what's happening there. Also the other thing that happens is we see people agree to be sectioned because there are so few treatment resources in the community. For many people, and this gets to what Alice, I think, was saying earlier, forced treatment, whatever you think of the efficacy of forced treatment, we know that many more people are resorting to it now than should, because many people want to access community. They're motivated, but they can't access the resources otherwise. So they take this step, and then you agree to treatment, you're eager for treatment, and you end up in prison. We have met people in that situation as well. And this just shows that, that we need to expand community-based resources as well. I just want to briefly say why this is unlawful. Addiction is a recognized disability, and this, sending people to a correctional facility just reinforces decades or even centuries of stigma. We used to criminalize alcoholism here, and so it's clearly a disability protected by the ADA. We don't send any other disease, there's no other disease that we would think about treating in prison. And of course, that's disability. That's what the ADA was designed to address. And of course, subjecting men, but not women, to incarceration for the purpose of treatment is clearly gender discrimination. And it violates due process. When we take away someone's liberty, which is what we're doing with forced treatment, we have to do it with the least restrictive alternative, and it has to be narrowly tailored to serve a government interest. Well, prison is far more restrictive than necessary, and using a prison does not serve the interest of treatment that is embodied in Section 35. So these, clearly the statute is unlawful, but it takes a long time to win in court, and it can be appealed. Meanwhile, they're sinking more taxpayer dollars into prison treatment, as I've just said, $36 million more. So we really can't afford to wait for litigation to take its course. Legislation, really, we've got to address this problem now with legislation. There's a real urgency to that. And I will let Representative Balser, who I imagine is going to be introduced, so I will not turn it over to Representative Balser, but she can tell you more about that.
Thanks so much, Bonnie. Yeah, next up, we are really lucky to have State Representative Ruth Balser here with us tonight. She's co-sponsor of this really important piece of legislation. Ruth is a state representative for the 12th Middlesex District, covering a portion of Newton. She's currently serving her 12th term in office. Rep. Balser is also the first psychologist to serve in the Mass Legislature and has been such a champion for issues related to addiction, mental health, and criminal justice. She's received countless well-deserved rewards and recognition for her advocacy. I'll also mention the other co-sponsor of the bill, Senator Friedman, was hoping to be with us tonight, but she's receiving an award tonight as well. So I'm going to hand it off to Rep. Balser, who's going to talk about the legislation in more detail.
Great. Thank you so much, Deb. And thank you all of you for organizing this. And thank you to all the participants for having an interest in this really important issue. It's been great, by the way, right back at you, Bonnie. Great working with you over these years together in this goal of decriminalizing addiction. So I'm going to talk some about the legislation, and doing that, I may repeat a few things that have been said, but just the way it's probably, if it's worth saying once, it's worth saying more than once. So Massachusetts is not the only state in the nation that civilly commits people who suffer from serious substance use disorder. Okay, we are not the only state to send people who are deemed to be at serious risk of harm to themselves or others to involuntary treatment. But Massachusetts is the only state in the nation whose statutes say that if the beds are filled, if the public health beds are filled, you can send a civilly committed individual to a facility in prison. So hold on to that. Massachusetts is the only state in the nation whose statutes say that if the beds are filled, we can send people for treatment to prison. So, I mean, I kind of keep thinking, like, what if we ran out of cardiology beds? You know, would we like say, all right, everyone who has a heart attack this week, we're going to send you to prison because there are no beds left in the hospital. That's what we're doing in Massachusetts with men who suffer from serious substance use. As Bonnie mentioned, several years ago, we in the legislature voted and the governor signed legislation to prohibit sending women to MCI Framingham as they used to be sent. And the state then set up facilities run by DPH and DMH instead. I remember the day that I voted for that bill, and I said, actually, to my colleague, Liz Malia, who some of you may know because she's been a champion for addiction as well. I said, like, why aren't we also shutting down MASAC? You know, I kind of, so since then, I've been committed to ending not only the criminalization, but as Bonnie points out, the gender discrimination that's involved in this. I like to compare it to our civil commitment issues for the mentally ill. I know there are a lot of healthcare professionals listening. We also have statutes in Massachusetts that allow for the involuntary commitment of an individual whose mental illness is severe enough that they are at imminent risk of harm to self or others. But there's a really big difference between that and Section 35, which is when someone who's suffering from an acute state of mental illness is committed, they are sent to a psychiatric hospital. There's nothing that says, oh, if the beds, you know, there are no beds at Worcester Recovery or whatever, we're going to send you to a prison. So the legislation that I have filed would really make Section 35 more comparable to that. As has been pointed out, it does not eliminate civil commitments. It does not eliminate involuntary treatment. That, from my point of view, is a different conversation. What this bill does is say that you cannot send someone who is suffering from an illness to a prison, that these are folks who have committed no crime. There is no charge against them. The only issue is that they're suffering, they're at risk of harm to themselves or others. I want to mention that I served on the commission that Bonnie mentioned, the commission that the legislatures established that recommended basically supporting this legislation, recommended prohibiting sending severely addicted men to criminal justice facilities. And there was opposition both within the commission and among my colleagues in the legislature coming from my colleagues in Western Massachusetts. And the reason they were opposed, they all agreed that MASAC is a terrible place and you wouldn't want to send anyone there. But they are fans of a program run by the sheriff of Hampden County. The sheriff is, we could say, a more progressive, rehabilitation-minded kind of person than MASAC or whatever. There are people very loyal to that sheriff and to that program, but they argue that the reason the sheriff does it is because there are no alternatives. And they are unhappy that when we prohibited sending women to prison, we set up all the programs in southeastern part of the state, and folks from Western Mass have nothing in their region. And so if my legislation were to pass, I would be depriving them of any resources. So what we did on the commission, and this was thanks to the Secretary of Health and Human Services, she sent out a request for information to the behavioral health providers in Western Mass and said, if we were to put out an RFP for programs, is there anyone out there who would set up a program? And more than a half dozen behavioral health providers said, absolutely. You put out the RFP. So this idea that the reason we send people to prison is because there isn't anyone out there willing to do it We heard this from the sheriff of Suffolk County as well when Mass and Cass was being talked about. And I just like to remind people that we are in a state with some of the best healthcare systems in the world, and certainly terrific behavioral health providers. And there's no reason. So I actually redrafted the legislation to say not only will we prohibit sending these civilly committed folks to, we'll prohibit sending them to a correctional, but we will make sure to provide regional services across the state. So we don't want to take away services from people. It's quite the contrary. In fact, I think one thing we all agree on is that if there were more services available, there'd be fewer people sectioned, because so often a loved one takes someone to court because they're despairing. They can't get their loved one help and they go to court. So I would urge all of you watching to, I'm looking at my own bill number. I never remember numbers. H2066 is my bill and Senator Friedman's is S1285. The bills are still being considered by the Joint Committee on Mental Health and Substance Use. And I encourage everyone to write letters to the committee to support. And later, I think later in the conversation, we'll talk a little more about advocacy. But that's what the legislation would do. It would say that once and for all, that addiction is not a crime, it's an illness.
Thank you so much, Representative Balser. That was an amazing overview of the problem and of your work, and that I think so important that you're taking into account the need for more services and really getting at the counter argument to that people give of, well, this is the only option. Say, well, no, actually, we need to expand the options. So with that, I have the great pleasure of introducing Dr. Ricardo Cruz. He is a primary care and addiction physician at Boston Medical Center, the Department of Medicine. He's a, I don't know what you call it, you may have some pithy name for yourselves, but he is a product of the BU School of Medicine and Boston Medical Center residency training in internal medicine. And he is a clinician educator and part of the core faculty for the internal medicine primary care training program there. His interests are in providing primary care and treatment for substance use disorders for vulnerable populations, including racial and ethnic minority communities and individuals with a history of criminal justice involvement. So Dr. Cruz is going to give us some insight on, as speaking as an addiction physician, of how he has seen this law play out in people's lives, and his understanding of all the complex, we know this is a complex issue, so I think having his insight as someone who's taken care of many people struggling with addiction is really insightful. Thank you.
Thank you, Alec. Thank you, Dr. Bukhman. Can you guys hear me? Okay, great. Tough acts to follow, but I'll try my best. So I'm really excited to share the stage with so many awesome discussants and talk about Section 35 reform and provide my perspective as a physician. So I want you all to imagine you are a person with a chronic medical condition, let's say diabetes. You've been told that your diabetes is uncontrolled. It's so bad that it can lead to serious health consequences. You tried to make, lifestyle changes, diet, exercise, but you have limited resources to do this. But you continue to struggle with controlling your diabetes. Your sugars are high and they're elevated. You can't break away from eating the high carb foods, drinking the sugary drinks, eating the sugary foods. You're considering getting on treatment, but before that happens, someone either in your family, your doctor, a police officer, decide that you need to be involuntarily detained to get your diabetes under control. So you go in front of a judge who agrees to this commitment. You're handcuffed and then taken to a correctional institution. You're processed like someone that committed a crime. You wear a prison-like jumpsuit and spend the majority of time in a jail cell. You are under the watch of armed correctional officers, and you're basically treated like a criminal. And to make things worse, You may not even get the access to the medications to help your diabetes. So does this make sense to you all? It really doesn't. Addiction is a chronic disease similar to diabetes, and it should not be treated in a correctional setting. These men deserve to be treated like patients and their addiction addressed in the community, either in a clinic, hospital, public health, or community treatment center. Addiction is a condition that requires a multidisciplinary approach by a multidisciplinary team. It should be addressed by physicians, nurse practitioners, nurses, social workers, pharmacists, psychiatrists, peer supporters like recovery coaches, and love family members. So then why would someone with a chronic medical illness be sent to a jail setting to address their illness? This doesn't happen for individuals who have diabetes, and nor should it happen for people with addiction. So there's ample evidence on the negative impacts that the carceral system has on health. Involvement with this system can have negative impacts on psychological health. Individuals may experience physical, emotional, and verbal abuse from others that are detained or by correctional officers. This can lead to worsening trauma, worse mental health. And then when it comes to addiction, individuals may undergo forced withdrawal if treatment is not offered for the substance use disorder. And this often leads to less engagement in life-saving medications when these individuals are ultimately released. This transition period from incarceration back to the community has been determined to be a very high risk period with increased risk for substance relapse, overdose, and unfortunately at times death. So why are we the only state that continues to send men struggling with addiction to a correctional setting to quote unquote treat their addiction? I believe that the Section 35 pathway that leads to a correctional setting has many ethical concerns. Obviously, the evidence of involuntary treatment is sparse, that it actually helps people. But sending individuals to a correctional setting under this practice makes matters completely worse. All this does is exacerbate stigma. It may actually prevent someone from getting standard of care for their addiction. The DPH report that was recently released in 2019, the Section 35 Commission shows that this practice can actually be harmful. It showed that individuals with a history of involuntary commitment were 1.4 times likely to die of an opioid-related overdose and 1.2 times likely to die from a reportable cause, for any other reportable cause. So as a physician, I've taken an oath to do no harm, and I feel like taking part in this process goes against this oath. I've seen many negative impacts and harm that my patients face after being involved with the criminal justice system or even after being sectioned. It makes their overall lives worse. They're unable to get a job, get housing, have access to food. And this leads to worsening social determinants, poverty, desperateness, worsening depression and anxiety. And these are all things that often trigger relapse on their substance. Involuntarily committing someone for their addiction to a correctional setting contributes to the overall harm, and this practice needs to end. Section 35 reform is long overdue, and resources need to be allocated to ensure there are sufficient community treatment beds. Funding for community-based programs to give individuals with addiction the appropriate support and treatment they need and deserve to help control their addiction. So I guess we're going to pass on to Cory.
I think Tyshaun's next, but thanks so much, Dr. Cruz. I think here at Boston Medical Center, I think a lot of us are having conversations about this, right? And how it applies to our practice and the ethics. And I think having a healthcare leader like you sort of make that stance is really powerful. So next up, I'm excited to introduce both myself and Dr. Cruz's colleague, Tyshaun Perryman. He has worked here at BMC. He identifies as an individual in long-term recovery. He has a bachelor's degree in mass communications and has worked in the role of a recovery coach for the past 6 years. He has over 20 years of experience in direct care street outreach. He serves on several community advisory boards. His primary purpose is to use his lived experience to strategically impact and empower organizations, communities, and individuals as it relates to recovery support services in racial health, diversity, equity, and inclusion. Tyshaun's going to talk about his personal experience with the 35 process and the reforms he sees as necessary.
Thanks, Deb, for the introduction. Well, what can I say? I'm excited. First of all, I'm excited to be amongst you guys, Representative Balser, Dr. Cruz, Attorney Bonnie, Alex. This is Cory. All y'all. It's just you guys just invigorate me, right? You just invigorate me for your work and strength and hope in reforming this bill. Reforming Section 35. I'm gonna dive right in because I really honestly have a lot to say. So Deb, you the moderator, help me out. Because I feel, I'm like I said, I'm very compassionate. There's a commercial that used to go around back in the day, the road game for minoxidil commercial, where the guy used to say that I'm not only the client, but I'm also the president. And with my history and my experience in the work that I do, my care and support for people with substance use disorder, it's the same thing. I'm not only a client, but I'm also the president. And with that being said, I'm gonna dive right in. I'm not only president because back in 1995, I was committed to DYS for 2.5 years for a crime that I didn't commit. When I was committed to DYS, I was sent to a place called Westboro Secure Treatment, in which I had 2 clinicians and I had group therapy. While they were giving me therapy, I was hoping that I could tell them that, that I wasn't guilty. I really wasn't guilty. But they told me that if I continued to say that I wasn't guilty, that I would be committed to DYS until the age of 21. This gave me the distrust of the criminal justice system. Not only that, but also my therapist, the clinical team that was there to support me, the only people that I knew as a 15-year-old to look up to and to, get advice from wasn't supporting. It was actually internally I was crying. Speed that up, put that here in 2020 where I had to Section 35 my father. It was the hardest and toughest thing that I had to do. In my community, growing up where I come from, to section somebody it's like it was taboo. It was like sending them to hell. Like you're not supposed to section anybody. It was the last resort. I talked with Dr. Cruz, and one of the stats that he showed me was that Blacks are actually in a study in 2018 showed that Blacks that only like 1.7% of Blacks were sectioned, as opposed to 84% white, 6.7 Hispanic. And so for Blacks, it's not a thing to do, section. So when I had to section my father, like I said, I felt ashamed. I was embarrassed. I did not want to section him. I was under pressure from my mother and from my aunts. But they wasn't a healthcare professional. They wasn't a recovery coach. My job as a recovery coach is to lead, guide, support, navigate individuals into getting them the best treatment that they can get. I had Dr. Cruz at the time. He was my manager. And, I couldn't even go to him to get help and support. I was left with no alternative but to section my father. And like I said, for a healthcare professional, that's devastating. For a recovery coach, that's devastating when you cannot make a phone call and call someone to get your father into treatment, when you know that you're about to send your father into the belly of the beast. I had a conversation with my father this past weekend about this. There's several things that he said that made him that said he had a very bad experience. Number one was he already knew that he felt like he was going to prison. He said, man, there's nothing like I was shackled, handcuffed in the van. When I arrived at the place, I was set in prison cells. He was like, you already know the food, the slop. I was eating slop. He said that that he had no canteen, that they don't even give you snacks. You have to buy canteen. a vulnerable person in a crisis situation in dire need has to buy a canteen and they have to pay $20 to $30 to $50 a week to make phone calls. The person has no money, they're in crisis, and you charge them $50. That's worse than an unlimited phone plan. Most unlimited phone plans anyway. But yeah, but they was charged. He was charged. There were fights inside there. He was there, and he told me that they still had the correction guards up there, and this is at Massac. He told me that when people leave the facility, once their time is completed, that they have no real crisis intervention or referral services upon leaving. So what happens is that they go out there, they're isolated, they're alone, they have co-occurring disorders. So their mental health kicks in. And so what happens is they're right back into the facility maybe a week or two later. And then once they come back into the facility, then they are given more time within the facility only to repeat the process of recidivism. And I just thought that was heartbreaking. Lastly, before I wrap up, I didn't want to go there, but when I heard Bonnie talk about the $36 million that is given by the government for Section 35, I just thought that was ridiculous. What I mean is Thomas Paine. I was reading Thomas Paine, Common Sense, and obviously, if the government says it, if our healthcare professionals say it, if the people that are involved inside of Section 35 say that Section 35 people involuntary civil commitment to prison for people with substance use disorder is inhumane, is terrible, then it's common sense that we should be able to place these individuals in other healthcare facilities where they can get the quality help and support that they need. So with that, I'm done. It's like I said, really, really, really heartbreaking, and so I'm done. Thank you.
Thank you so much, Tyshaun, for sharing your story and being vulnerable with us. And Tyshaun provided some really powerful testimony at the legislative hearing a few months ago, which is great. And last but not least, we have Cory, Cheney. Cory identifies an individual in recovery. During the pandemic, Cory was incarcerated several times in Section 35, which he will share more about. His story really highlights the various ways in which we continue to criminalize addiction here in Massachusetts. Cory, though, also found recovery through voluntary treatment. He received his college degree and now has a 1.5 years sober. He's inspired to share his story to help build awareness. Currently, Cory is an intern at Cultivated, a first in the nation jails to jobs program for the cannabis industry, and was also supported by the F8 Foundation during his reentry. And Cory's going to explain more about his recent experience of being in Section 35. Ooh, I think you're muted, Cory. Want to make sure we can hear you. There you go.
Sorry. So yeah. Wow, that was a powerful story right there. That made me rethink a lot of things, and I do want to say I appreciate us taking the time to really break this down, because there's so much stigma to it, and there's so much unknown from the information that is given to a lot of family members. So for my story, I battled, addiction for a long time, now going over 10 years, which is, crazy. I'm 31 now. And, I had my up and down battles, thinking I had it. And then, I, fell through, thinking I had it another time, and then boom, I fell through. But the fact of the matter was I was always trying, and I wasn't giving up, because I knew I could do it, but, I didn't have enough information, and I wasn't really taking things as serious as I should, using my age as a very bad way to kind of approach addiction. So when things got, unraveled to a point where now it's like my family, they feel they lost hope, in me, and that I wasn't going to get better. So I was kind of just thrown out, in the streets. I had a job, but I had no car. now I had no place to go. So it kind of was like a shock into reality, like, wow, now everybody, I guess, wrote me off. So I guess, I'm going to do what I do. And, when I do that, it's usually not good. So not having that support really drove me into a spiral. And what ended up happening was I was very, very messed up to a point where I don't even know what really happened. But when I came to, I remember sitting in a hospital with my hands cuffed to the bed. And this is a no violent crime, meanly, just to let you guys know, this wasn't, anything vicious. So I fell off a 2-story building. And apparently, thank God, I didn't end up getting seriously hurt. But I didn't get the proper treatment that I really should have, because I think there's a stigma when, and I don't blame it on the nurses, but I feel like when somebody gets rolled in there, cuffed, and they don't know everything, it gives that bad treatment, as in like, okay, this guy's unpredictable, But so I didn't get the proper treatment. I probably had a concussion. I probably, I think I had a tear in my knee, and then when I ended up getting, going to jail and then getting brought in front of the judge. And meanwhile, I'm still foggy. I'm still not, coherent in the most part. So I didn't get the idea of what kind of was going on. But my brother ended up sectioning me, and he didn't have enough knowledge on it, I don't think, and my family really didn't either. So I can't say that, they thought I was probably gonna get help, but I really didn't. So when I went into these facilities, it was actually pretty sad to see that the environment. And meanwhile, with my knee all messed up, I was still shackled. I was still, I barely could walk. So I think that kind of made things worse. So what ended up happening was I go into these sections and it is horrible. There's that's when COVID was going around, but no one knew what was going on. So everybody was sick. No one was getting the proper treatment. I lost weight in there, and then I ended up getting more upset being in there than I was to try to get help. And people were getting in trouble because of either family members not being or being upset with them, and them not even having a substance abuse. So it ended up seeing my eyes got open through the situation, but I ended up getting worse going out of there, and I ended up getting incarcerated. And things ended up getting worse and worse until I took the time to finally get that chance to go into voluntary treatment. And I feel like that's like needs to get pushed more and shown more that, hey, listen, forcing somebody into getting sober isn't going to work. It never works, and it never will work. But when somebody volunteers or gets shifted like the Section 35, into the right resources, that that money that we were just talking about, there's so much ways to take those funds and be able to push it in a generation where it can actually do more good than harm. And they see the stats, they're not like it's hidden. So they know it's not working. We need to do better. And from the grace of God, I ended up doing very well after getting the help I needed, but it took time. It took work. It doesn't just go for the first time. So, all I wanted to really push for is that there is great reform that I ended up going into as Mass Cultivated to be able to get a degree. And now I'm able to help people get back on their feet and, resume building, all this. So I just want people to understand that this bill is very important. It might sound small, but I think it's going to make a big impact. So I'm just happy to share, my little story of trial and tribulations that actually ended up working for the best. So thank you, and God bless.
Thank you so much, Cory. I think, Cory and I got to know each other through this process. And I think, one of the interesting things, about your story, Cory, was how when you were in court, that you wanted to go to voluntary treatment, right? You were sort of asking the judge, which I've seen play out a lot of times working in the courtroom. You were asking to go to treatment, and sort of through misinformation and miseducation of family, you know, you were sent on a Section 35 when you could have voluntarily gone to treatment. And I think that was, we see that a lot, and that's sort of a missed opportunity. So
Right.
next, we're gonna pivot to sort of action, right? So we heard a lot about how, you know, Section 35s clearly, there's a step towards reform. They remain a tool for healthcare professionals, police, and loved ones. I think the question remains, how do we minimize the harm of that practice? And I think this piece of legislation offers a solution to that. And so now we want to sort of advocate for the change. Rep Balser, do you want to jump in and maybe explain some actions folks can take? And I know folks in the chat were excited to hear more about that, to sort of have legislators vote in favor of this bill.
Sure. So the bill is still in committee. It was the committee put it in an extension, which actually, oddly enough, is kind of a good sign. It means they're working on it, but it means there's an opportunity for people to weigh in. So I would encourage people to send letters to the Joint Committee on Mental Health and Substance Use. Maybe someone could help me out and put a link to the Mass Legislature page for that committee, and it will show you the names of the chair people, the House and Senate chairs, as well as the members. You can send an email to the chairs. You can copy all the members and just say, you know, you're writing in support of H2066. And another thing you can do is write to your own, write or call your own rep and senator and urge them to weigh in with the committee and to support the bill. This will just be the first step. If the committee supports it, it'll go on to another committee and maybe another committee. There are these steps. So what you really do want to do is contact your rep and senator and ask for their support and their involvement in advocating for the bill. Oh, and I should add one more thing is it's also good to communicate with your networks. I think there are a lot of organizations represented here. I think, you know, social workers are part of NASW, or, so, you know, the different groups that are here. It's good to encourage people in your network to write to their reps and senators. You know, you write to yours, but you can encourage them to write on theirs. And we just want to really raise this. One of the things, you know, we like to point out when we talk with people in the public is that there are literally thousands of bills filed every session. And sometimes it's not that people are even opposed to a bill. It's a matter of getting it on the radar screen and educating people. And I would encourage you, when you contact your legislators and when you contact the committee, to share your own personal experience. If you're someone, either a professional who has experience that you want to draw on, or if you're someone who's has lived experience of your own, such as some of the folks we've just heard from. Legislators are very moved by, it's more important to tell the kind of personal experience like what we heard just now than a whole lot of statistics or data. So I would just encourage you to contact your legislators.
Thank you so much, Representative Balser. And speaking about talking to your networks and bringing the advocacy to the people that are near you, I'd love to turn to you, Dr. Cruz, and just explain how you see the role of advocacy as a medical professional in this area.
Yeah, so I think as a healthcare providers play an important role in advocating for their patients and the communities they provide care for. Advocacy is recognized as an essential component of professionalism for physicians and should be a key component of graduate medical education. And unfortunately, sometimes it isn't. And as a clinician educator, obviously I care about sort of training future doctors and ensuring that they are well equipped to take care of a variety of medical conditions, but then also we got to address the patient as a whole, and advocacy plays a huge component of that, specifically when it comes to legislation that is going to overall impact health. We've been very lucky at Boston Medical Center in the primary care training program. worked on advocacy projects. We work on a yearly advocacy project, and in 2019, we were very lucky to collaborate with PLS, Bonnie and Liz Matos's team, and the residents really got excellent experience learning how to advocate for the Section 35 reform, and it led to a lot of interesting pieces. The residents were able to participate in oral testimony in front of the state legislation. Residents and the faculty contributed to a perspective piece that was published, I believe, in Commonwealth magazine. So obviously it's a as a healthcare provider, we should be advocating for these things that impact health, and we should be obviously reaching out to our legal colleagues, because as a medical provider, I don't know how how to write declarations and the specific language, and I imagine as a legal profession, they may not understand sort of the health impacts of various illnesses, addiction, et cetera. So it really is an opportunity to sort of cross collaborate and cross train each other, and hopefully leads to reform and change.
Great. Thanks so much, Dr. Cruz. I'm wondering, Tyshaun or Cory, you guys can maybe talk about the important role of using your voice, your lived experience as someone in recovery or in a peer role in this advocacy process, and either how that felt for you, or sort of, Tyshaun, I know you've been using your voice for quite some time, how you've been able to do that. And I know we have folks in the audience with lived experience who may also want to be doing that work.
Yeah, I feel like a voice, especially from lived experience, goes a long way. And for me, I'm a huge person in doing the step work that, because you gotta, when you're in these moments of addiction, you've got to work on yourself too. It's not just the drugs and alcohol. There's underlying issues. So I got my mental health situated, and I feel like with that, using your voice as not a stigma towards mental health as much as it was. I know it's getting better now. I feel like by those personal experiences and those stories really touch a lot of people. So I really feel like this is like the time right now to really push for this, because things are not getting better out there. So I feel like the more people hear about these stories and how it impacts not just the person, but the families, the families get hit hard too. And, if we can start, expressing more, like, just with just our, our stories and how we overcome, I think that can shed some light that there is hope on the other side. That's what I get on.
Yeah, for a lot of people that are healthcare professionals, but are also people in recovery, advocacy is important, because I think one of the in the old NAA literature it talks about giving freely what was freely given to you. So you want to be a part of supporting recovery and helping people to part of advocacy is helping yourself. Strengthen, for me, it strengthens my recovery. I think so. I joined advocacy organizations. I joined MORE, which is the Massachusetts Addiction and Recovery. I said it wrong. Massachusetts Organization for Addiction and Recovery. I joined MORE. I stay connected to healthcare professionals that with Deb and everybody, Section 35 Advisory Board. And I just reach out and reach out to different Boston Public Health Commissions. There's recovery centers that look for people to support their causes and advocacy, so you can get connected to recovery centers. But mostly most important thing is that as a person in recovery and a healthcare professional, there's nobody that knows substance use disorder like you do. So your voice is important in both the office and professional setting, but also as it relates to other individuals, being that liaison to fill in the gap to support others.
Thanks so much, Tyshaun. I'll also add to that. I know there are probably a lot of social workers on the call because we're offering CE credits, and I'll sort of share a piece of how I've, used advocacy. So I used to work at MCI Framingham when Section 35 still existed there, and that's sort of what has prompted my advocacy in this space, sort of seeing women sent to prison on 35s and seeing sort of the harm that was done with that. And I got involved with NASW, so National Association of Social Workers, because I felt like I wanted to advocate for legislation like this. And, this bill in particular, we've gotten NASW to push to sort of, sponsor, put weight towards and support. And so that can be done whatever professional organizations or advocacy groups you're involved with, right? So sort of like raise the issue and use your voice to have those organizations stand behind it. So I definitely encourage that, whether it's addiction legislation or other areas of reform.
Can I say one more thing?
Yeah.
I actually, with the advocacy too, is, we were talking about it a little bit prior, is remember we were talking about how we can take the organizations that are doing help, like the F8 Foundation, Mass Cultivated, into these programs, that having people be able to get, back on their feet, and have an organization that can help carry that burden a little bit. Those foundations that I just found were so helpful. And the F8 Foundation does so much help to transition you from where you're at in that moment to kind of getting that help and then going on to the real world, because there needs to be more long-term programs that help out, with somebody that's trying to get clean, because short-term help doesn't work.
That's great, Cory. And I know our toolkit includes some various organizations that might be helpful for folks that are interested. It looks like we do have some time for some questions, and I know I took some from the chat, but if folks have particular questions they want to put in the chat right now, we're happy to sort of pose them to the panelists. One question that stood out to me that I know comes up in this a lot, and anyone can answer, but I'm maybe looking at Bonnie for this one as the attorney, but this question of how do we define risk to self, especially when we think of addiction, and actually maybe Dr. Bukhman or Dr. Cruz can also comment on that, because I think it's a really tricky one, especially when the court is defining that, right, and not sort of a medical professional.
Yeah, and I think also we have a panelist, Mark Larson, participant Mark Larson, who oversees some of the representation of people who are sectioned. I honestly, there is no standard. And I think what we saw since the opioid crisis exploded, I've heard judges basically say, with fentanyl, that if you're addicted to opioids, you are almost by definition endangered. But I think others may be better equipped to be more specific. But my understanding is it's subjective, and there's not a lot. The clinicians give input, but I think just the very fact of addiction